Continue our discussion of chemical dipsticks, urine analysis. Let us now take a look at blood. Now, up until this point, in part one of our lecture series, we went ahead and talked about in great detail urobilinogen and bilirubin and the difference between those types biochemically. And it's important that you get those down. Now we get into blood as being part of our analysis in the urine. Detects RBCs, hemoglobin, myoglobin. What are the differences? Well, let's say that you end up having an RBC that has to squeeze through the glomerulus. Yes, I'm being dramatic. As an RBC squeezes through the glomerulus, is it possible that it might then become disfigured? Mm-hmm. Do you know what kind of RBC that's called? I just kind of gave it away. It's called dysmorphic. Amazing, huh? What's morphology mean? Shape. What's dys mean? Messing it up. So a dysmorphic RBC would be an RBC that would be more of a glomerular origin. Are we clear? So the type of RBC that you see becomes important and relevant for us. What if you find just RBCs in general in the urine? That could be anything. What does that mean? That means that the RBC could be from damage of your tubule, not from the glomerulus. Or it could be damage down in the urinary bladder, maybe due to cystitis. Do you see the difference now? So what you want to do is anatomically separate your urinary bladder from your kidney, and even within the kidney, separate your tubules from your glomerulus. Then we have hemoglobin and myoglobin. Remember, myoglobin, and you find this in the urine, would then give you your pinkish red, myoglobinuria, and the way that this occurred was due to crush injury. And then I gave you hemoglobinuria as well, and that would be red. Remember, that patient woke up in the morning and saw red urine. Panicked a little bit. What happened? Wake up in the morning. Or maybe after exercise. Those are acidotic environments that the patient was in prior, either during sleep or during exercise. Acidotic, respiratory, metabolic, respectively. And then during this process, in a patient with paroxysmal nocturnal hemoglobinuria, ended up having red urine. Hematuria, renal stones being an example. Hemoglobinuria, intravascular hemolytic anemia. So, Dr. Wright, you just told me about PNH. Yeah, I did. What do you think PNH is? Paroxysmal nocturnal hemoglobinuria. Not that I'm asking you what the abbreviation means. I'm asking you what category of hemolysis is it? Is it intra or extravascular? If it's hemoglobinuria, it has to be intravascular. Is that clear? But Dr. Raj, what about extravascular? Remember that sickle cell patient? Sickle cell disease, homozygous, acute chest pain. There was issues with hands, dactylitis. That's extravascular hemolysis. What was significant in that patient? It was jaundice. That's significant. Hematology is interesting, isn't it? Myoglobinuria, crush injury. What else might you find with myoglobinuria? Use common sense. If your muscle is actually being broken down, skeletal muscle, shall we say, got into an accident, a crush injury, what else would you expect to find apart from myoglobinuria? Isn't creatine kinase a component of your skeletal muscle? Of course. So you have increased serum creatine kinase. Hope that's clear. Let's move on. Nitrates, you find this to be interesting. Many times in microbiology, you end up talking about this, but to differentiate pathologically what kind of urinary tract infection your patient is suffering from, you'll find this to be neat. Nitrites is my topic. It detects nitrites produced by nitrate-reducing uropathogens. These include your E. coli. How important is that? Very. One of the most common causes of urinary tract infection, something like E. coli, gram-negative organism. And what might you be looking for here? It's nitrites. Okay. Now, the test is sensitive and specific, respectively, 30, 90%. Specific at 90%. It requires, this is where it gets really interesting, requires approximately 4 hours for nitrate, reducing uropathogens, to convert the nitrate into nitrite. Now, the reason that I'm being so dramatic here about the names is because don't confuse this with esterase, right? Even though E. coli has an E, do not equate it to esterase. This is nitrite. In patients with Urinary tract infections frequently have what? Increased frequency of urination, which explains the test has poor sensitivity. Do you see as to how wonderfully this is explained in terms of why sensitivity is a measly 30%, but specificity is a high 90%. Think about your patient, urinary tract infection. What are they doing? Hey, doc, I have a burning sensation, most likely a female. And what is she doing? She's going to the bathroom a lot so she can urinate. Do you think that perhaps that she's actually evacuating the organism during this time and not allowing for a sufficient amount of time for the conversion to take place? Of course. So sensitivity could be quite low. But if your patient is presenting as such and you know this about the pathogenesis, then you have properly managed your patient. Now, this versus esterase. Leukocyte, what does that mean to you? Pyuria. What does leukocyte mean? WBCs. What type of WBC might you find most notably with bacteria? Neutrophils. If it's esterase, then it detects the esterase in your neutrophil. Well, you kind of know about neutrophil in pulmonology or respiratory pathology. And the reason I say that is because neutrophil up in your lungs, when it comes to, let's say, take care of antigens in great abundance, something like maybe smoking. What's that enzyme that neutrophil releases there in the lung? Good. Elastase. At some point, if you release too much elastase in the lung, what's your diagnosis? Very good. Emphysema. This is neutrophil down where? In the urinary tract. And what enzyme is it releasing? Esterase. 80% sensitivity infection. Examples. Now, be careful. Why? Listen. Urethritis. I want you to go anatomically from distal to proximal. Urethra is infected. Urethritis. Are you going to find neutrophils? Of course. Okay. Cystitis. Infection where? Urinary bladder. Are you going to find neutrophils and esterase? Yes. Pyelonephritis. Go more proximal. Kidney infection now. Abscess formation. Flank pain. Back here in the flank. And with pyelonephritis, neutrophils? Yes. Dr. Arch, what the heck was your point? My point is this. WBC casts. WBC casts are different from neutrophils. Is that clear? What do you mean? Casts are only coming from the kidney. Casts will never be found in the urethritis. Casts will never be found with cystitis. Casts are almost always found with pyelonephritis. In all three, would you find cells? Yes. If it's bacteria, what kind of cells? Well, obviously, neutrophils. What is this test? Esterase. Move on. Sterile pyuria. Neutrophils present, but negative standard urine culture. Now, one big organism, such as chlamydia, trachomatis, urethritis, TB, and drug-induced interstitial nephritis. Now, all of these in which you would find neutrophil, but you come back to be negative for culture. The two big ones here, chlamydia, and the other one would be interstitial nephritis. Further discussion we've had with interstitial nephritis in other lectures.